Good morning, friends. Good morning. My name is Ara Serjui, and I have the distinct honor of serving as the Vice President for Advancement at Guilford College. As is our tradition, let's go ahead and start with a moment of silence. Thank you. This is our second last Thursday of the month coffee chat with Guilford College. I want to go through a couple of housekeeping items with you. Everyone has been automatically muted upon entry. However, if you have something urgent that you would like to express, you can unmute yourself, but ideally we'll keep everyone muted so that no background noise can interfere with the program. Also, the chat function is limited to participant with host, and I serve as your host today. You're welcome to type in the chat function questions that you might have through the program, and I'll be paying attention to that. And if there is time at the end of the program, we will get to those questions that you might have for our speaker today. With that, I'd like to go ahead and start with the introduction of Michele Malotky, who is a professor of biology and has been at Guilford College for 17 years. Michele earned her PhD in neurobiology and physiology from Northwestern University in Chicago. Her research at Guilford currently focuses on medicinal ethnobotany, ancient traditions, and antibiotics. She is also part of community-based research projects looking at health disparities in the Greensboro area. Related to this work, Michele and her colleagues at North Carolina A&T University were recently awarded a grant by the National Science Foundation looking at the impact of service learning and authentic research experiences on student recruitment and retention in the fields of science. Michele co-founded the public health program at Guilford College in 2017. Professor Malotky today will discuss the role of public health in preventing health crises, assessing risks, developing solutions, and helping countries and communities maneuver the crises and recover from them. So with that, welcome. Welcome, Michele, and thank you very much for being our featured speaker today.
Okay. I'm pleased to be here. Thank you for inviting me.
Great. You're very welcome. So Michele, we have heard a lot about public health in the past few weeks. What can you tell us about public health as a discipline, but also as a profession?
Okay. Well, in terms of public health, it's the science of protecting and promoting health within communities. And so not just individuals, but rather larger communities. And it requires a lot of different approaches. So education, surveillance, research, policy recommendations and things like that all fall under those categories. In terms of training, traditionally it has been a master's or PhD kind of degree that people get when they're in public health. However, in recent years, there's been a real call for further education earlier on during an individual's degree. So Guilford, along with others, have responded to that call and have generated public health programs. They tend to be very interdisciplinary. So you have all of the different liberal arts represented. You have the natural sciences, social sciences, humanities, business, arts, all interplay to provide a background for students that are studying this as a discipline. In terms of careers, of course, it's as diverse as the training itself. So you have individuals that are biostatisticians or epidemiologists. Those are what we sometimes refer to as the disease detectives that go out into the field and collect data on where the disease is and use that data to help identify where it started, where it's moving, and to help come up with different types of interventions that will help reduce disease. But you know, it goes well beyond that as well. So I mean, you have those individuals, but you also have the healthcare providers, the healthcare administrators, you have public health, community health workers and environmental scientists that are out in the field testing water sources and food that you eat at restaurants. All of those things encompass a part of what we consider public health.
Great. Thank you very much for that overview. Your own training is in immunology. Can you tell us about COVID-19? What exactly is it?
So COVID-19 is actually the disease that is caused by a virus. Okay, so they have all of these terminology that they use, but it's actually the SARS-CoV-2 is what the nickname is for. It's for what's referred to as the severe acute infectious disease agent. And this virus is tiny. Okay, we consider it submicroscopic. So you think of a light microscope or something, which is a traditional kind of tool that we use in biology. This is too small to see even with the highest magnification. So I, as a hobby, am a seamstress. So I'll use a pin, the little pins that you use. On the head of a pin, you can fit over hundreds of millions of viruses can fit on that head of a pin. So that gives you a sense of just how tiny they are. We consider them parasitic because unlike a bacterial cell, which is one much larger and has all of the machinery within the cell to divide, viruses don't. They depend upon the cells in which they infect to cause to replicate and spread. And so they really are just essentially genomic information, which means like DNA or RNA that gives our inheritance information, right? Okay, so it's the viral inheritance information surrounded by a protein coat that often have some kinds of proteins that emerge from the surface and will help them in order to bind to and infect cells. Okay, so that's the virus itself that causes disease.
Okay, thank you for explaining that. So SARS-CoV-2 is the virus that causes COVID-19.
Mm-hmm.
And so how is this disease, if you would, similar to other diseases that we've experienced in the past that have been successfully tackled with vaccines? We've heard about smallpox, measles, Ebola, influenza. Most of us have had the flu. Some people have experienced those other diseases, either personally or loved ones. But over the course of time, vaccines have been used to prevent them or treat them.
Mm-hmm.
And so what can you tell us about those diseases and their similarities or differences with respect to COVID-19?
Right. Okay. So one of the things is that with many of these diseases, the initial signs and things like that are very similar, right? Which is a real challenge for medical professionals when somebody comes in presenting with certain types of things. So things like temperature, you get increased temperature, and you have perhaps have rashes on the surface of your skin and things like this. Much of that has as much to do with our immune response to the virus as opposed to just the virus itself. And so we have many aspects of our immune system that are involved in this that we'll get to later, I hope. But in any case, thinking of some of the other diseases, smallpox is a good example, and I'll use that because that one is one where we have had real victory with, and in terms of public health. This is caused again by another virus called the variola virus. It's very old. If any of you were lucky enough to be here a couple of weeks ago when Tim talked, he talked about some of the early pandemics that occurred with this pathogen. It leads to fever and rash that eventually forms pustules, and those pustules have virus in them that then can be transferred to individuals. So in this case, simply, if I took this jacket off, if I had if I had smallpox and I handed it off to someone else, someone could actually, the disease can be transmitted through that. But it also is through respiratory droplets, similar to what we see with COVID. Again, respiratory droplets, as I'm speaking, there is a humid air that's coming out of my mouth and my nose. And, if you put a phone or something up close, you'll see it forms kind of a cloud. That's the respiratory droplet. So that is, so we all transfer those very easily. So it's again, transmitted very easily. And which is part of the problem with smallpox. In the case of smallpox, though, it has a mortality rate of over 30%. So about 3 out of every 10 people die, which is much higher than what we're seeing with COVID. But in this case, the big difference is that this is a pathogen that is exclusively found in humans, okay? There is no animal reservoir. And so once we were able to begin a vaccination program where we vaccinated at least a large percentage of the population, okay, it had no one to jump to because the people that, you know, who had been vaccinated were immune to it. They had developed an immune response that kept them from, or was able to attack any virus that came in well before any symptoms and disease could emerge. And so once we got to a level of what we call herd immunity, okay, and that is where a certain percentage of the population is immune, either through natural causes by getting the disease or through vaccination, that the pathogen has no one to leap to. And it doesn't mean that everyone is vaccinated, and it will vary from disease to disease. So depending upon how easily the pathogen transmits, it's something called the reproductive number, or R naught. You'll hear that, you know, if you read things in the news, you'll hear about that. For some diseases, it is very high. So something like mumps, for example, has an R naught of about 10 to 12, which means for every one person that gets the disease, they infect 10 to 12 other people. For COVID, it's more like about 1 to 3, right? So a knot is 1 or 2 to 3, something like that. So for every person that gets it, they infect 2 people, okay? That can still spread pretty rapidly, but as the higher that number is, the more people that need to be vaccinated or immune to the disease before that herd immunity works, okay? So in any case, with smallpox, we successfully eradicated the disease by through vaccination programs. The last natural case that occurred was back in 1977. So we haven't had any natural cases since then. The only place the virus lives is in a tiny little vials that are stored away somewhere in very, hopefully, secure freezers and used for research in order to help develop vaccines if we were ever having a situation where it was released into the public again.
Well, let's hope that it always stays in that vial and,
Yep.
and doesn't get out. But you know, it sounds like we know a lot about viruses and how they spread, and yet it appears as though with all of that knowledge, COVID-19 was not predicted, or was it predicted? And certainly its spread was not prevented. What can you tell us about why?
Right. So your question as to whether it was predicted, that was a good question. Right? I would say that we have predicted it. And there are people in public health and in science that have for a long time predicted this kind of thing to happen. In fact, just back in October of this last year, in October of 2019, there was a group of individuals that got together. This was organized through Johns Hopkins University. But they got a group of individuals together that were from the from public health, from business, from government, and health practitioners, and they did a role play game essentially, right? So Dungeons and Dragons of COVID, and in this case, they were given a scenario, and they had to make decisions about what were the appropriate measures to do, and then kind of played out what happened. And afterwards had a debriefing and coming up with recommendations. And I can tell you that the results were similar to what we saw. Okay, so in terms of the things that happened, it led to spread of disease nationwide, worldwide, but you know, we're looking at the United States here. And, but they did come up with a lot of recommendations, many of which are things that are being discussed now. But between October and January, unfortunately, a lot of those didn't get implemented. And you know, nobody knew when it was going to happen. But we have had cyclic cases of pandemics coming through. They tend to be what we call zoonotic diseases, meaning that they're coming from an animal reservoir. So for example, you know, you hear about the bird flu or the swine flu in the past. We've had pandemics of those, and it's because these kinds of diseases, because they have natural reservoirs where they can grow and thrive, and the animals don't necessarily get sick, they're just a carrier, a vector of the disease, right? But then it's when it gets passed to humans, and mutations have to happen. The virus isn't the same when it moves. And that's why it just doesn't happen every time you come in contact with a bat or a pig or a bird, right? The virus has to change. But when those changes happen such that it recognizes humans, this is where it can lead to this kind of rapid dissemination of a pathogen.
Very good, thank you. So how does that knowledge relate to the current situation that we have?
Right. So one thing I'd start by saying is that a lot of the decisions that are made are based on two factors, okay? The first of these has to do with the idea that the level of scientific knowledge and technical knowledge is important, right? So how we think diseases are caused. And again, this relates back to some of the things that Tim talked about, right? It's what we call disease concept. So how we understand what causes the disease, of course, is going to impact how we decide to treat it, okay? In this day and age, of course, we understand that there are these pathogens that cause disease, but that wasn't always the case. And so that's one thing. The other thing has to do with the current public values and popular opinions of the time. So giving just a quick example, if you look back to 1918 flu, which is probably the last pandemic that has been as devastating both economically as well as elsewhere otherwise, this was a flu that killed, they estimate, it's probably an underestimation, is somewhere between 600,000 and 700,000 people in the United States. So it's well beyond what we've seen yet with COVID. But it happened during the war, during World War I. And in this case, there was a general understanding. They actually thought initially it was a bacteria instead of a virus. And we could talk for hours about this. I won't. And I love this stuff, so I could just go on, but I'll try and keep it brief. But at any rate, because it was the wartime, there was also the need to maintain the public's morale for supporting the war. Okay, and one of the ways of doing that was things through war bond parades, where people would come together on the streets and, they'd want them to buy the war bonds to help support the war. And so when the first real outbreaks of the flu happened, public officials sat down and tried to decide what to do. Do we have these parades or do we cancel them? What will be the response of the individuals, the people? And they were worried, of course, about people panicking and losing support for the war that they needed. And so they decided to go ahead with these parades. So people lined the streets and everything. And in places like Philadelphia, within days, their hospitals were overflowing with patients and, just devastating. But there are different things that go into play, deciding to do that. Woodrow Wilson had to make decisions as to whether to send troops across in boats, right? And many of those boats became almost floating coffins by the time they reached the French shores because of flu, spreading throughout the troops that were being transported. So awful, devastating things. But, it was during the time of war, they needed to get those troops to the location. So a lot of tough decisions go into these things, and it always isn't necessarily help. If it was just the public health aspect of it, they'd say, no, everyone needs to stay sheltered at home and forget about the war, right? But that isn't going to work, so.
Well, that's a good segue for the next question in terms of then how do we need to go about stopping this virus from spreading? What are some thoughts you have about that?
Okay. So this is a good point to kind of make the distinction between a cure and a treatment, okay? And again, I apologize to anyone in the group that, this is all understand it completely, but at any rate, I think it's important to make this distinction. So in terms of, treatments, we've been using or been researching, looking for a number of treatments to help alleviate the mortality or morbidity, how many people either die or get the disease. And because of the time frame, of course, we're using a lot of what we call repurposed drugs. So we're using drugs where we know that they're safe to take. They've been used for treating other things, but we have found drugs that in those cases also seem to have an effect on the virus. And so there's been a lot of work doing that, but this works usually by either stopping the replication of the virus once it enters into that cell and hijacks it and starts replicating, or blocking its ability to enter, essentially, locking the doors of the cell to keep it from entering. Or the third thing is, in most cases of really severe respiratory syndrome, part of what they think it is those chemicals that are released by our immune cells are dysregulated and just lead to just lots of these chemicals being released. It's called a cytokine storm. And they know of drugs that can help reduce that kind of response, to help at least, again, reduce the mortality rates. But for stopping it, ultimately you need a vaccine. And so, of course, everyone has heard that there's lots and lots of labs around the world that are working on vaccines. They've repurposed their labs to do this kind of thing as well. And as I mentioned, a vaccine is usually something where either you take the pathogen and you inactivate it, make it so that for whatever reason it can't either enter into the cell or can't replicate. But it allows our immune system to recognize it and respond to it and build up a memory response, okay? So and that's a kind of form of generating what we call immunity. There are cells that fight off the virus, and then there are also cells that turn to memory cells, and they kind of back up and say, I'm not going to fight this battle, okay? I'm going to wait for the next invasion. And so they hold back, but they are primed and ready so that they can respond very quickly if the disease is, if they're presented with disease again. That's what you're doing with a vaccine. Essentially, you're generating those memory cells without getting the disease. And so there's lots of different kinds of vaccines that are being generated. And there's hopes that maybe sometime in turn of the next year, in January or something, that there may be some that are actually ready to be starting to be distributed and tested. But there's a number of things that have to be done first to make sure that they're effective, first of all, right? That they don't do any harm initially, and before they can be tested in the general population.
Right.
Okay.
Well, that makes a lot of sense. It raises the question for me, however, with respect to whether the virus will actually quite ever disappear. You mentioned earlier that smallpox, for example, jumps only from humans to humans, but COVID-19 also has a connection with animals. So can we ever completely eliminate COVID-19?
No, not likely. Okay, so this is like the flu. Okay, the flu is one that tends to be found in organisms such as birds and pigs and so on. And for COVID-19, for the coronaviruses, many of the coronaviruses, their natural host is in bats, and bats make up a huge percentage of the mammalian population in this world. It might be things that people don't want to think of, and they play important purposes too. So it's not something where we want to just get rid of all the bats to get rid of coronavirus, right? That's not going to help us. But there are practices we can do to help alleviate it. So there will always be these hosts and these reservoirs where these viruses exist. But for example, these things tend to happen in areas, for example, where there is a lot of destruction of ecosystems, deforestation to make more fields in order to grow cattle so that there's enough meat for people to eat. So if you kind of follow that chain along, you recognize that if people reduce their meat consumption, right, and provided other kinds of livelihoods for individuals that were using deforestation and farming in areas that shouldn't be happening, there would be less likely that we would destroy those ecosystems or at least come in contact with these organisms that carry these viruses, and there would be fewer of them emerging. But Ebola, HIV, coronaviruses, these are all due to this interaction with organisms that harbor these diseases. And why they keep emerging is because we continue to move out into these areas. So that, there is a lot of sustainable and conservation practices that actually directly impact the emergence of disease.
That's fascinating, and thank you for kind of setting the stage for one of our future programs, which will actually examine the role of sustainability and the environment in the current crisis. But it also really shines the light on the significance of public health, and especially in the way that Guilford has approached the creation of our public health program. We'll get to talk about that a little bit later. But this bringing in the various components of history and an understanding of the science, but also human behavior, effects of all of that, if you would, on creating or preventing perhaps health crises like the ones that that we have experienced before and the one that we have right now. So let's switch gears a little bit into specifically public health and talk about first, how has public health in the past played a role with the other diseases that that we talked about, and then we'll go from there to the role of public health for COVID-19. What can you tell us about past diseases and public health's role?
Sure. Okay. So again, Tim did such a nice job a couple of weeks ago going through talking about some of the historical situations, pandemics, the plague, smallpox, things that affected individuals. And before we really had formal public health, there were still practices that emerged that we continue to use today. So one of the things he talked a lot about was quarantine, right? And if I recall, the word comes from something about the ship staying off the harbor for 40 days before they could disembark. And that's still used. I mean, obviously our, shelter in place at home is a form of quarantine in a sense, and asking people that are sick to remain, isolated or separated from other individuals in their house, and of course from anyone in other households or other places in their community. And so that practice has been maintained for a long time. But taking a different example so that I'm not just repeating things that Tim talked about, I'll use an example that happened in New York in the turn of the last century, the early 1900s. And so this was at a time when public health was brand new. And we had just, we were really starting to understand that the germ theory, which is the theory that emerged that suggested that pathogens such as bacteria and viruses cause disease, was starting to be recognized more. Tim had talked a little bit, again, for any of you that were in the audience for that talk, about one of the previous disease theories was something called the miasma theory, where it was just bad air, that led to disease. And so the example I'll use is one where, bad air would kind of fit, right? It was a disease that tended to happen in poor areas. And the disease I'm thinking of is typhoid, okay? Which we still have today. That's not a disease that's gone away either. But it tends to be fecal oral is what they say is a transmission, which means that it can move through your digestive tract and you eliminated it, and then it gets into water supply. And then if that water is contaminated and you wash things or drink the water, you'll get the disease. And so it tended to happen in very poor areas, but there were some cases that emerged in very affluent neighborhoods in New York and Long Island. And so some of the early public health officials started to look into this. Of course, this is a time where, nobody worried about it too much until it hit an affluent population. But that's for the ethicists to talk. We could talk about that on another talk. But in any case, they did another possible thing that we tend to do in public health, which is what is called contact tracing. So by identifying the households and, interviewing everyone in the household, what emerged was that the common denominator thread that connected these families was the cook. And the cook was an Irish immigrant named Mary Mallon, okay, but she's better known as Typhoid Mary. And she moved from place to place. And as she moved from place to place, disease emerged in these places. And so eventually what they did is quarantine her. They took her against her will, and she fought and fought to be released. She was on an island called North Brother Island off New York, Manhattan. And eventually they let her out, and but told her that she could no longer work in food preparation, which was a more distinguished kind of in the hierarchy of household employees. And she, so she worked as laundress and other things until suddenly there were cases that started to emerge again. And one was in a hospital in New York. And sure enough, she was back working in the kitchens. And so then she was removed to the island. So this is again, a very early example, but of some of the kind of practices, so that they tested her, and it ended up that what she was a carrier. And this is another thing that relates directly to COVID, because there are diseases like this where individuals carry and shed the pathogen despite the fact that they don't show any symptoms. And so she couldn't understand why she was being targeted, because she wasn't sick. Why would she be the one causing the sickness, right? But they were able to do testing of fecal samples and identify that she was a carrier in this case. So the testing, the contact tracing, quarantine, these are some of the common practices that we see even today that we're using, a similar thing that happened back then.
Well, thank you. So that's very interesting, talking about the history and how public health has played a role with prior diseases, the testing, the contact tracing, you talked about vaccines and herd immunity, and all of those factors. And I'm now interested in knowing how we have taken that information to apply it, if you would, to this pandemic. How is public health playing a role specifically with this pandemic? And, again, bringing into the conversation things like testing and so on.
Mm-hmm. Okay. So, as we have become a global society, right? We are moving from place to place. And so it really takes a coordinated effort of lots of different organizations at different levels. So, these pathogens don't know borders, right? They can cross borders without any checkpoints and go from place to place. And that's what we see with what we call a pandemic, when it moves worldwide, okay, and spread worldwide. And so you need to have organizations that are involved in surveillance and monitoring at the global level. So you have things like the World Health Organization that has each country reporting any kind of diseases that look, there's a number of reportable diseases that any physicians or anything that come in contact, they need to let the government agencies know, such as the CDC, the Centers for Disease Control. And the CDC will then go on to alert the World Health Organization to say, we've got a case of Ebola here, and, so that they can be monitoring it. They help provide a lot of guidelines and things like that for different countries. And sometimes provide resources as well. So, depending on the countries, again, in this day and age, we need to be worried not only about the diseases that hit our borders, but others, because of the fact that they can move from place to place. And so it's important to be looking worldwide for the emergence of these diseases and trying to regulate them before they have a chance to travel beyond the borders of wherever they emerged. So in the United States, of course, we have a lot of government agencies. We have the Centers for Disease Control and National Institutes of Health that all play a role in surveillance, research, and education, policy decision-making, things like that. And then you get to the regional or the state public health, and then regional and local. And there's also at the individual level too, right? So there are all of these different components, but it bridges a number of different things. So they need to train all of the laboratory technicians. So right now, as new kinds of assays are being developed, we need to have people that are trained on how to run these assays. And so these agencies help with the training and distribution of tests and things like that, as well as the kind of policy regulations that you hear about in the news in terms of CDC providing guidelines that the government accepts or doesn't, and whatever, and moving forward.
Well, thank you. That sets the stage really well for something I've been thinking a lot about, and I'm curious to get your perspective on it, and that is the, healthy, or perhaps even sometimes unhealthy, degree of tension between these various bodies that you've talked about, whether it's the World Health Organization or our various entities in the United States, our federal government, state governments. There is just so much, if you would, disagreement and discord. And I'm just wondering, from your lens, why do you think that is? How does public health fit into this tension, and how can we, what can we learn from this experience, and how can we emerge from it better?
Mhm. Well, as I used, the example that I used earlier with the flu, okay, you have a couple different things that often play against each other. So in terms of public health, I think of it like, with physicians take an oath called the Hippocratic Oath, which is first do no harm. And in the case of public health officials, their training has been to provide the best understood methods of keeping a population healthy. And so, but those methods or the recommendations that exist, such as sheltering in place, closing businesses and things like that, don't always fit with either what the population's values are or other concerns that need to be addressed. So, for example, we're kind of in a stage, unlike perhaps during the war, where people tended to come together to as a group, for the good, I'll send my son off to war and potentially sacrifice someone I love for a better good, right? But there's kind of been the ascension of individualism that's happened in more recent years, where individual rights have played a very huge role in a lot of people's psyche in terms of how they think what their rights are and how those rights can be expressed. And that often plays against any kind of disease prevention methods, right? Because some of the actions that we need to take are not only for our own safety, but the safety of others as well. And so that plays against each other. In addition to that, of course, is, we're in a market economy. And so closing down businesses and things also reduces people's livelihoods. And there's a lot of people that don't have considerable savings that they can live off of. And so you have those kinds of things that factor against what the public health officials would say would be the best practice to do to avoid disease. And so those are the kind of factors that go against each other. But there's a lot of, again, this would be a great interdisciplinary class to just talk about this. In fact, I'm quite sure that this will be the topic of numerous conversations on campus next fall.
Yes, actually, I think it's to some degree happening already as well. Yeah. And certainly at the federal and state level, we are seeing a lot of a phased approach to the reopening of the economy. And I'm curious, from your perspective and from a public health lens, why do you think it's better that we are doing a phased approach? What are the benefits of doing a phased approach to the reopening of our communities?
Right. Okay. Well, like I said, because of the tension between it would be safe for us all to just stay home until there were no cases left and we could all emerge. But we all have to eat, and we all have to have, livelihoods that will allow us to survive. And so these phased approaches are really to try and slowly, try to increase the economy again. So people have money to feed themselves and things like that, starting primarily with businesses that are most essential, right? And less likely to require that lots of people come together. And so, things like museums and places like that will open later than places like stores and things that where people need clothes or something like that. Okay. Anyway, so it's, I think it's a way to try and make concessions for the economic needs that go against what otherwise would be the public health recommendations. And so it's kind of a compromise, if you will. The important thing to remember from this, and this is the thing I worry about. For example, I was just talking to my mother who lives up in the border between Wisconsin and Minnesota right now. And as some of you may know, I watch the news carefully, particularly for up there, since my folks are up there in a retirement setting, and which tends to be one of the more vulnerable kinds of populations. And recently, the state of Wisconsin decided that the shelter-in-place kind of order was unconstitutional, and so they have essentially eliminated it. And my mom gets, wants to get up and get around, and so she can get into her car from the garage and drive around and come back without ever going outside, keeping her windows up, and she does that. And so she said to me the other day that, the businesses downtown were all open, people were eating, nobody had masks on, not 6 feet apart, anything, it's just like back to normal. And I'm afraid that the message isn't getting strong enough across that these phased openings does not eliminate, it's not things back to normal, that people need to maintain the physical distancing, wearing masks, washing your hands, trying to avoid touching your face where you might have virus that, you rub into those mucous membranes and can enter. So those kinds of practices still need to exist. And, I'm afraid that there's too much of the message of we're opening and things are going back to normal, as opposed to recognizing that we may have a new normal for a while, right? So it's, that's what it is. It's a compromise, is the phased opening. But what's the other thing I just want to mention, I guess, is that, it's decided at the level of the state, right? So each state has that choice as to when to open. And that is important because, each state is different, both geographically, population densities, things like that, such that the same requirements may not be necessary in each state. But the example I gave you between Wisconsin and Minnesota, of course, Minnesota is being more restrictive in its thing, but there's nobody monitoring who goes across that border, right? So each state has to decide for itself what, the best means, and try and follow the regulations as best as possible, but it will be different for each state. So, I think the phased idea is a good idea, but I think that there really needs to be more stress on the fact that that opening isn't back to normal.
Thank you for clarifying that. So this phased reopening is really a compromise between public health recommendations and policy advisors and economy advisors, kind of reaching this place of, okay, well, we have to do this, but let's do it in a way that might be best and most safe for our populations. I know back in Washington State, for example, the phased approach has been done by county. And so it's not across the whole state, but rather counties are going through a phase 1, 2, 3, and 4. And there's some coordination that's taking place between the county that sits at the bottom of the state and borders Multnomah County in Oregon, where Portland is. Mm-hmm. And so that level of coordination between the states, I think, is also helping them in the way that they're approaching a phased reopening. Mm-hmm. I'm going to switch gears a little bit and kind of wrap up with this question before we go to some questions that were submitted by our audience members in advance of the program. You've referenced the talk that was given by Professor Tim Kircher for the first coffee chat in in April, and brought history into your conversation quite a bit. And so, in your opinion, how can public health and history be put together in an educational setting? And maybe this is a good time to talk about how you have gone about creating the public health program at Guilford.
Sure. Actually, I should say that I do know of at least one class that's happening this summer at Guilford, where the history department is looking at the history of a number of different pandemics, and then having the students kind of reflect on that in relation to what's happening now. So when I said that those conversations will start next fall, you're right, they're starting now. So there are those things that are already going on. I feel very lucky at Guilford because I have such a wonderful, rich group of colleagues in the different disciplines, many of which have interests or ties to, in one way or another, to the area of public health. And so it was a very natural, organic kind of way of being able to develop a program. We didn't have to hire a lot of new faculty because there were so many people on campus that we could already reach out to. So it's a very interdisciplinary program that we developed at Guilford, again, partly because the discipline itself is a very interdisciplinary discipline. And so how we designed it is to have a foundation in public health, which is common across the country. There are organizations that say these are the kind of things we want our students to, or students should have and know, and we followed those guidelines. And then we also added 3 tracks so that students take some classes that are similar, but then they also take classes that are more in line with their own interests. So for those that are really interested in disease or the relationship between sustainability and how that relates to public health and things like that, there's a natural science track that they can pursue. For those that are interested more in history of disease or looking at other kinds of aspects of cultural things that impact disease, we have a social science, health and behavior track that students can pursue. And then for those that are more interested in the business and policy end of it, we also have a business and policy track. So students can, kind of follow where their interests are. And in addition to that, the new curriculum that has been developed at Guilford as well includes a component where students it's called the Collaborative Quest, and students have the ability to select courses and identify some kind of concern or topic that is an issue and start to apply some of the classroom work to addressing that issue. And they can either work in collaborative groups or work on individual thesis projects and things like that to accomplish this. It fits, again, so well with public health. We have lots of relationships through the Bonner program and other programs where students are working out in the community. The grant that I just got is related to that. Students are doing health disparities projects and real research that's going out in the community and working with communities that are underserved populations. So all of these things fit very well together at Guilford. It just was a very natural fit here. And so I was very pleased that that we were able to, something that we've been discussing for a long time, and it clearly seems to be of interest because we have, I think, over 35 majors already after just about a year and a half of it being in place. So that's pretty exciting.
That is very exciting. And the way you're explaining it to me, it makes so much sense that we have a collaboration between really kind of, political science, biology, psychology, business, communications. It's all kind of coming together. And then the students are actually, because of our curriculum, given and not just an opportunity, but almost kind of required to then take what they've learned in the classroom and take it out into the world and apply it. And that concept of an applied and practical liberal arts education really comes to life in the way we have created both the public health discipline at Guilford College and how it fits within the new Guilford Edge curriculum.
Mm-hmm.
Thank you, Michele, for taking the time to answer my questions about public health. We have some questions from our audience members that were submitted before. So we're going to get through some of those. And then if we still have time, I'm going to address a couple of questions that have come through chat. The first question is from Lynn in Graham, North Carolina, who says, "Hello, Michele." And then Lynn asks, some 13 or so sailors on the USS Roosevelt who had COVID-19 and recovered have recently come down with the infection for a second time. Does this mean that an effective vaccine will be even more difficult to develop?
Yes, that's a perfect question. And coming from one of my biology colleagues, I appreciate that very much. Thank you, Lynn. Yes and no. Okay, so each pathogen, I didn't go a lot into the immunology, but there are certain types of pathogens that will generate a stronger response. And some will lead to responses that will hold memory cells and last for a long, long time. So for example, when they tested patients that had survived the 1918 flu, they had come down with disease and survived it. And this has just happened back in, about 10 years ago. These individuals, of course, were old. They'd been, they'd had the flu 60, 70, 80 years ago, and they still had antibodies, these proteins that our body makes to help block the entry of viruses and things, suggesting that memory lasted a long time, right? But it isn't true for all things. So, we have certain vaccines that we have to get boosters for. One is, you know, although chickenpox, for example, the virus that causes chickenpox lasts for a long time, they recommend people getting another vaccine as they get older to avoid a related disease that's caused by the same thing, shingles. And so our immune system is only able to generate a response that lasts so long, and some are better than others. And so, you know, that's an important question. The reinfection reports that we've seen, there have been two main ones that have been identified. One is in South Korea, where they identified individuals that came down with second positive testing. In those cases, they further tested those individuals, and the virus that was being recognized by the test was no longer infective. It was fragments of the RNA of the virus that it was recognizing. And so in their case, they're saying that it wasn't, you know, it wasn't a reinfection that we need to worry about, that the people didn't get sick. In the case that you're referring to with 13 naval sailors, in this case, a percentage of them did get sick, so they came down with sickness again. And so that suggests in at least some cases, they did not develop enough immunity to fight it off. One of the things that hasn't been talked a lot about in discussions about, you know, the disease, how severe it is and everything, in the general population anyway, has to do with viral load, right? So depending upon how much of those viruses you actually are exposed to will obviously affect how bad the disease is. And what we don't know in that on that specific ship on the Roosevelt, the initial infection caused a lot of people to be positive, but it isn't clear how many of those individuals that came down with sickness again ever had symptoms the first time. They may have been asymptomatic and not had a strong response. And the second exposure gave them more. We just don't know, not all that information has come out yet. So, but if it is that they had symptoms the first time and should have developed a response, then your question about the effectiveness of a vaccine. But at least the testing that they've done in monkeys, which is a close relative that we can test in before we go to humans, suggests that some of the vaccines that we're looking at are actually pretty effective. So keep our fingers crossed, because that's really what we need.
Yes, I think we all are keeping our fingers crossed for that. Okay, great. We have another question from Fred in Chapel Hill. And Fred asks, are serological tests specific enough to be useful?
Okay, right. So there are essentially two kinds of tests right now that we have, okay? One is a molecular test, and this is where we are able to actually go and detect any DNA or RNA in this case, that inheritance material that might be found in our bodies in the cells. And it's similar to what they do with forensic work, where they can test blood samples and do what they call a DNA fingerprint to identify, somebody that may have caused is responsible for some crime. And so it's a similar kind of technique, but in this case, we're trying to detect the virus. This tends to be very specific. It tends to take a little while. So it's the test that, people don't get results back right away. There have been a few what we call point of care tests that have been developed. Abbott Laboratories is one of the examples, where they're able to do this molecular testing, but much faster. Unfortunately, with much faster, it isn't as accurate. And so that still needs to be worked on before it's at a point where it's really effective. The serological test, the one that Fred refers to, is instead of looking for the virus, you're looking for the antibodies that your body has made. What this tells you is if you've been exposed to the virus or not, okay? And whether perhaps you might have some immunity then. It doesn't tell us whether you have the virus anymore, if it's still active and if you're still shedding it or spreading it to other people or not. So that alone isn't enough. So yes, your concern there is correct, that the serological test alone isn't enough to tell us whether or not you're infected.
Wow, thank you. There's so many elements to this. Rachel from beautiful Portland, Oregon asks if in the context of everything that's happening, and particularly with respect to public health, does policy drive societal behavior or does behavior drive policy? And she specifically notes wearing masks as an example of this question.
And that's a perfect example, right? So in this case, if you look at that, I'd say that it's not one or the other, that both happen, okay? So if I remember the question exactly right, when it's the behavior that drives policy, okay, this could be seen, for example, in the early decision by public health officials and the government to not require people to wear masks, okay? And the reason for this is because they recognized, as you see every time a hurricane happens in this part of the country, people run out and get milk and bread. I'm still trying to figure out exactly why that is. I don't know. But in any case, people have a tendency to hoard, right? And to get as much of whatever they need to keep themselves healthy. And the concern is that those safety devices, masks and things like that, would very quickly diminish in availability for the first responders and the people that really need them because they're at the forefront of the fight against the disease. And so the decision was made not to suggest that people needed masks, right? Now, again, from a public health perspective, the mask probably would be helpful from day one, right? But because of the concern about people's response or their behavior toward that action, they chose to develop a policy that suggested otherwise. Okay. Once masks were no longer readily available for the general population, and they recognized that maybe it would be a good idea for at least people to make homemade masks or some kind of device that covered their mouth and reduced some of those respiratory droplets, that they started recommending that. And so here, then again, you're moving from where the policy drives behavior. Now people are wearing more masks, right? And that those masks also help people, I think, to recognize not to touch their face. And, just a reminder that we need to be cognizant of our distance between people, because they aren't terribly comfortable. And so it just is kind of a physical reminder of the precautions that we need to take. So that kind of, I think your face mask example is a good one of showing how that, policy sometimes drives behavior and sometimes it's the other way around.
Yeah, thank you. Well, and it's interesting how masks have quickly become another form of accessory that people are having a lot of fun with.
Yeah.
Just like you would with a scarf or a tie, and also somewhat politicized.
Mm-hmm. Yeah. Oh, yeah. Yeah.
We have time for just one last question, just a few minutes here. Dan in Brown Summit asks a question about Guilford's readiness and preparedness for having students, faculty, and staff return to the campus. And in some ways, Carol in Greensboro has also chatted to me a similar question. How do you prepare for having in-person classes, getting the residence halls safe? All of these very important questions. And Michele, if you'd like to take a stab at that for a couple of minutes, and I have a little bit of information to add to that as well before we wrap up.
I'll look forward to hearing that too. Sure. Obviously, you're hearing lots of different responses by different educational institutions. Many of them are, saying initially, except for the University of California system, most of them are saying we're planning to be back, right? I think all of us recognize that the way that we teach, that we prefer to have that interaction, that there's things that go with that. I mean, this is wonderful, our being able to, gather as a group virtually and stay safe and do this. But particularly for those of us that, are in labs, Lynn, if she's still in the audience, she's an ornithologist. She has to get out there with the birds, right? And so students do need to come together for some of those kinds of things easily. There are ways to do it virtually. And so we're looking into all of those options. I think it's only prudent that we do that. But our hope is that we'll be back on campus in the fall. However, I very highly doubt that it will be back to normal. Okay. I think it's going to be a while before we're back to normal. So there are a number of things that are being, considered or suggested for ways to make the campus safer. So there'll probably be more flexible kinds of instruction, both to keep both at-risk students and faculty safe. So that if there are faculty, for example, that are not comfortable with being on campus and possibly being exposed to the virus, that they may be able to run their classes online. Okay, and maybe have tutors on campus that then meet with students and help to facilitate things if they want, the students want to congregate. But the class sizes will probably be smaller. We luckily live in a part of the country where we can be outside for a good part of the fall. And so I'm guessing that there will be a lot of people that decide to choose to move outside because being outside does resist, there isn't in an enclosed space, those those respiratory droplets can remain in the air for up to, they think, about 15 minutes, something like that, right? So I leave this room, 10 minutes later, somebody else comes down and sits where I am. Those respiratory droplets could still be floating around, right? So, those kind of things have to be common. So we have to think about the scheduling in terms of, when populations are moving in and out of rooms, possibly move outdoors for some of the things that we do. Housing density and food preparation is going to have to be done differently. I know I've been thinking that anybody that's in the industry of making compostable plates and cups and things like that might want to think, there may be an increased need for that in the fall from institutions that are serving food, but that would be a safer way to do it and environmentally more sound if we use compostable. So things like that. I think the big thing that I think of is coming up with a creative way to foster community without large group gatherings. So we need to think about perhaps we could do things like housing based on schedules or majors or disciplines so that there's pods of students that are eating together and working together, that are moving around campus and things like that. But we also have to come up with ways to still generate the kind of very rich community that a place like Guilford really prides itself on, or, tries to develop. And there are ways to do that. I think of just the ways in which I've connected with people I haven't seen for a long time through mechanisms like this to make sure that we're really still in community with one another. And that's going to be the biggest challenge, I think, because even if we're on campus, we won't just all be able to congregate as a big group in Dana Auditorium or something,
Thank you very much. That's a great response. And in fact, we do have a health and safety task force that was created by President Fernandez about a month ago. And it's comprised of our Director of Public Safety, Director of Facilities, Director of Residence Life, Dining Service, and concurrent to all of the work that they are doing about examining all these different facets that Carol so carefully enunciated in her question to me in chat. Right alongside that, we also have our provost and faculty colleagues. I believe the clerks committee has an ongoing conversation that is taking place around the delivery of instruction. How will that be done? That will be safe, that will be very deliberate about meeting those commitments that Guilford has to a very high level of personalization of the delivery of education. Dr. Michele Malotky, everyone, thank you so much for joining us for this conversation with this wonderful colleague of ours. I hope that you all have a great rest of the day. Please mark your calendars, June 25th, 10:30 a.m. Eastern Time, for the last Thursday of the month coffee chat with Guilford College. I hope you have a wonderful day. Thank you, Michele.
Yep. Thank you, everyone.